Good afternoon again. So what is an ideal implant? Some material which is inert, lightweight, biocompatible, non-inflammatory and which also remains stable and fixed to the surrounding tissues. The search for material continues because we still do not have an ideal implant. As I mentioned in the earlier presentation, horsehair was the first implant to be used. Later on, silk thread, metals like magnesium, titanium were used subsequently. Until date, polypropylene and silicone have been the most successful implant materials. So polypropylene is a synthetic polymer which is used in intraocular lenses, suture materials and also in glaucoma drainage implants. It is biocompatible but it incites more fibrosis and inflammation. In silicone, silicone rubber is the material of choice and it has been used in the implants. It is less inflammatory and induces less fibrosis than polypropylene. What is the pathophysiology of a glaucoma drainage device failure? Now there are differences in the rate of inflammation and fibrosis between different materials. Polypropylene is known to incite more reaction compared to silicone. There can be differences between different implants of the same material, that is mainly due to the surface texture, the rigidity, the shape of the end plate and the flexibility of the end plate also play a role. So what happens is the inflammation causes protein binding, cytokine release, and there are micro movements of the plate against the sclera which induce a microscopic shearing of the surrounding tissues, which ultimately lead to the implant failure. The choice of the material also influences the initial inflammatory reaction. The shape, size and the rigidity of the end plate influence the fibroblast growth and the extracellular matrix deposition. Surface area of the plate is inversely proportional to the intraocular pressure. The surface topography and chemistry also influence the wound healing. The smoother surfaces have lesser inflammation and hence a better bleb. Surface roughness in this study by Corres et al. Was found to be highest with the silicone Ahmad valve and least with the Molteno implant. The fibroblast adhesion was in turn higher with increasing roughness of the surface, and the hypertensive phase may also correlate with the amount of fibroblast adhesion. The initial hypertensive phase is related partly to the surface area for the aqueous resorption, partly to the roughness of the base surface. Due to surface area differences, the Ahmad valve has a higher incidence of the hypertensive phase than the Baerwelt implant. Polypropylene is found to be more inflammatory than silicone. In this prospective randomized trial of polypropylene versus silicone Ahmad glaucoma valve, the silicone had a better success rate. The mean IOP was significantly lower in the silicone Ahmad valve and there was a higher incidence of tenon cyst formation in polypropylene than in silicone Ahmad valves. And polypropylene in this study has been found to be a risk factor for failure of the device. There are some newer modifications coming up. Jacob J.T. et al. Have done a study of modified Baerwelt implants where the implant was coated by adding porous cellular ingrowth material on the posterior surface of the plate. And at 6 months, the fibrous capsule formed was found to be thinner than the non-modified implants. The amount of type 1 collagen adsorbed on the surface was the same, but type 3 was found in lower concentrations around the modified implants. So to end, an ideal implant is not yet available, but silicone appears to be the most biocompatible till date compared to others. There might be ways to improve the available materials by modifications, but still studies will be needed for future. Thank you.